Okay, making this video to discuss one unusual feature of COPD on chest X-rays. We have discussed the topic before, probably twice, but very common features were discussed. But for those who do not know or have not been following me, I'll discuss them again briefly. COPD is most commonly caused by smoking. A rare cause is alpha-1 antitrypsin deficiency, which is a protein with a primary function of protecting lung parenchyma. COPD stands for chronic obstructive pulmonary disease. It is also known as chronic obstructive lung disease (COLD) or chronic obstructive airway disease (COAD). Please note the word obstructive here. Lung conditions are sometimes classified as either obstructive or restrictive. COPD is a type of obstructive lung disease, which means people who suffer from this condition are unable to completely exhale all the gases they should or would have been able to if they had healthy lungs. There are mechanical reasons that obstruct outflow of air. There are a few conditions that fall into this category, and COPD or COAD, as it is also known as, is one of them. COPD includes emphysema and chronic bronchitis. Other examples of obstructive lung disease are asthma, bronchiectasis, and cystic fibrosis that I can remember at the moment. In contrast, there are conditions which are classified as restrictive lung disease. Restrictive lung diseases in which people cannot inhale enough amount of air. Obesity can be a very good example. There is too much fat around thoracic cavity, which physically limits how much lung can expand. Lung fibrosis is another common example in which lung parenchyma is hardened and is not elastic enough to let the air in lungs cannot expand enough. People with COPD have difficulty in breathing because they cannot exhale the amount of air a healthy person would. This mostly happens because of damage to alveolar walls, which is known as emphysema or narrowing of airways, as in bronchitis. Exhaled air comes out more slowly than normal, and at the end of full exhalation, an abnormally high amount of air, which is high in CO2, may still remain within the lung. So once again, there are two chest X-rays in front of us, both PA views. The one on the left is a normal chest X-ray, and the one on right shows all the classical features of emphysematous lung disease. There are 4 or 5 classical features, and all are present here on the X-ray on the right hand side. Hyperinflated lungs, which means increased lung volume. 11th posterior rib is visible through lung parenchyma as compared to 7th or 8th rib on the X-ray on the left hand side, even after allowing for the differences in sex. This is a male patient and this is a female patient. As you can clearly see here, this is a female patient breast shadow here. Another typical and classical feature is flattened hemidiaphragms. Hemidiaphragms have lost their usual dome-like shape, and this is the classical feature of COPD. There is a generalized bilateral increased radiolucency, which means blackness with decreased lung marking. If you compare the lung marking here and here, these lungs have decreased lungs marking as compared to the normal X-ray on the left hand side. A small cardiac shadow as compared to normal cardiac size on the X-ray on the left hand side. On the lateral radiographs, a barrel shaped chest. So this is a barrel, so barrel shaped chest. This is a normal lateral view. So this is how normal chest should be, and this is a barrel shaped chest with increased anterior posterior diameter. This is normal anterior posterior diameter. This is increased anterior posterior diameter on a lateral chest X-ray. Please note once again, flattened hemidiaphragms as compared to normal dome shaped hemidiaphragms. So these were the classical features of COPD on chest X-rays. However, we are here to discuss a far less common radiographic feature of COPD, which is known as Sabre sheath trachea. The word sabre actually refers to a sword, which is the reason behind such name, I presume. You can see trachea is quickly tapering down before dividing into main bronchi. Right and left main bronchi are wider than intrathoracic trachea. This is intrathoracic trachea, and it should be the other way around. This is a 3D rendered image from a image of trachea from a CT scan that clearly shows the deformity of intrathoracic trachea, decreased coronal diameter, and corresponding increased sagittal diameter of trachea. This deformity leaves patients extremely debilitating, unable to breathe. And so once again, Sabre sheath trachea sign refers to marked coronal narrowing of intrathoracic trachea on frontal views with corresponding sagittal widening mostly visible on lateral view. And I don't have a good example unfortunately right now. Sabre sheath trachea is identified most often in older patients, particularly in males over 50 years of age. 95% of patients appear to suffer chronic obstructive pulmonary disease. Not all patients with COPD, however, show Sabre sheath deformity, and that's why it is one uncommon radiographic feature that you would see on chest x-ray, but you will come across some x-rays that do have it, and if you do, you should look for the other signs of COPD, which means hyperinflated lungs, flattened diaphragms, barrel-shaped chest on lateral view, and overall increased air density on both lungs, etc. Before I go, I used this article from this website, and thank you very much for the person who uploaded these wonderful images. Thank you very much.